Jacques, thank you very much for the invitation. Professor Sami, it's an honor. Amir, we know so many years when I was a young medical student because my father, he was a neurosurgeon, was very friend of Professor Sami. Well, this afternoon we're going to talk something controversy. Trigeminal neuralgia without vascular conflict, the role of interfascicular neurolysis. This is the new classification of trigeminal neuralgia. It divides idiopathic when the MRI is negative. Classical is when there is a demonstration on MRI or during surgery of neurovascular compression, not a simple contact. And secondary, recognized causes as tumor or CP angle, AVM, and multiple sclerosis. But we as neurosurgeons, we follow more the classification of Burkill. Type 1, when more than 50% is episodic pain. Type 2, when more than 50% is constant pain. But perhaps it will make more sense to divide type 2TN into 3 subdivisions. Type 2A is cases of pain more than 50% constant, but in which there is a minor component of episodic lansinosity pain. Type 2B, cases of 100% constant pain, but they have a history of lansinosity pain. And type 2C is patient with pure constant pain and no story of lansinosity pain, and maybe these patients are not trigeminal neuralgia. So we can discuss it after. So the etiology is a compression of root entry zone by a tumor or by the artery, can be idiopathic, around 20–30%, and multiple sclerosis. Pathophysiology, many theories, no problem. But we follow Janeta's theory of vascular compression. When there is a pulsatil vascular compression, the root entry zone causes demyelination of the trigeminal nerve, establishing ectopic generation of spontaneous nerve impulse and emphatic transmission to the adjacent fibers. And surgical displacement of blood vessels will lead to remyelination. So here you can see a diagram of Janeta that shows that the root entry zone of the trigeminal nerve can be variable in length and may extend to more distal portion near the trigeminus. And also MASSIN in this publication in 2002, more than 50% of his cases was outside of the root entry zone. But what's root entry zone? There's some confusion. You see here, this is not root entry zone, this is transitional zone. So really, there is a confusion in many neurosurgeons until now. So this is an excellent paper of colleagues from Turkey. They study 100 trigeminal nerves. They find that the cisterna portion are from 8 to 15 millimeters long. And look this nice photomicrograph. This is the root entry point. This is 100% of central myelin, so this is the root entry zone. And this area of central myelin surrounded by peripheral myelin, this is the transitional zone. Another interesting data is only 1/3 of this initial proximal cisterna nerve is the root entry zone. It's just 1/3. In any case, past the 50%. So the conclusion of this work is that root entry zone and transitional zone of the trigeminal nerve are distinct sites, and that these terms should never be used interchangeably. This is another nice work from Japanese. And look, that's beautiful photomicrograph. This is the central, the root entry zone, and this, the transition zone. Well, this is for medical student going to pass. So there's many treatments for trigeminal neuralgia. There's no perfect method. But everybody agree the gold standard is microvascular decompression. However, neurovascular compression is not found in all patients with trigeminal neuralgia. In this series, around 60% there were no vascular compression. This is a nice paper of Kimburg-Kiel that trigeminal neuralgia occurs and recurs in the absence of neurovascular compression. They study with 3D MRI, and 29% of the type 1, they don't find vascular contact, and 80% in the type 2. With MRI, with this sequence, the sensitivity is between 87 to 97%, and specificity 50 to 100%. This is a type of vascular compression, but right now we know that nearby or just a contact doesn't produce trigeminal neuralgia. It's normal to find some contact in the trigeminal nerve in any patient. So this is really what is compression. This is a distortion. Here's an indentation. So this patient will have a very good outcome after vascular decompression. This is a very important paper, the significance of neurovascular contact in classical trigeminal neuralgia, or a very group of Marburg. So they conclude that neurovascular contact causes displacement or atrophy of the trigeminal nerve is highly associated with the symptomatic side in classical trigeminal neuralgia as opposed of neurovascular contact in general, suggesting the degree of neurovascular compression will thus be important when selecting patients for surgery. And this is a paper from Pittsburgh of Raymond Sekula, the significance of degree of neurovascular compression in surgery for trigeminal neuralgia. They studied 79 patients with 3D MRI, and they found contact only 38% in the symptomatic nerve and 54% in the symptomatic nerve, and severe neurovascular compression in almost 60% in the symptomatic nerve and 9% in the symptomatic nerve. So conclusion, patient with classical trigeminal neuralgia undergoing MVD, severe neurovascular compression on preoperative MRI is a strong predictor of an excellent surgical outcome. This is a patient that I operated in 2014. I didn't find no vascular compression, so I do massage compression with a forcible bipolar, but the results were very bad. The patient also have an unruptured ACOM aneurysm. So 5 days of severe pain. I did a balloon compression until now, free of pain. So I was searching the literature, what else I can do? And I found partial sensory. I have some cases with good results. Trigeminal root compression doesn't work in this case. Gentle bipolar coagulation, interfascicular neurolysis that was never heard before. Radiofrequency, electrode application to the root, laser application to the root. Very dangerous. So the problem with partial sensory is the loss of sensitivity, dysesthesia dolorosa, and the possibility that you can have anesthesia dolorosa. So I find internal dolorosa. What is that? So I find in papers in English from our colleagues from China. The first publication was in a journal from China by Li in 1995. It's a procedure in which all or portion of the trigeminal nerve is divided longitudinally along its fibers between the pons and porous trigeminus. Not always possible. Sometimes it's very difficult to dissect all the fascicles. This is one of my first cases. No compression. It's unfriable, this trigeminal nerve. And in this case, I ended with compression with force. The results were very, very good. And a mild hypoesthesia. This is a patient, male, 45 years, typical trigeminal neuralgia, no vascular compression. And there's a work of Kimburg-Kiel, especially in young people, a woman, there isn't vascular compression. Well, the evolution of the patient was very good and complete relief of the pain, with also very mild facial hypoesthesia. Here you can see the superior petrosal venous trunk, mesencephalic vein, cerebellar inferior vein, and pontine vein. And this is a case of a woman of 220 pounds, the typical trigeminal neuralgia, and you see the mesencephalic vein pass through the trigeminal nerve. So what we can do? Coagulate. We can clip the vein and wait 10 minutes to see if the cerebral swelling. We don't want to take any risk, so we prefer to do, in this case, interfascicular neurolysis. And the results were very, very good. Oh, okay. Well, this is the series that I found is published in the English literature, and you can read the initial pain-free is very good, 80, 85, 80, 98. And I have 77 cases, initial pain-free, almost 93%. And usually it's mild hypoesthesia, and usually it's transitory. These are my results. In 91% of the cases was a mild facial numbness, not bothersome, and usually transitory. We have 4 cases, facial numbness somewhat bothersome, and in 2 cases was very bothersome. If you want more details of this technique, I published in March 21 in the Brazilian Journal of Neurosurgery, and this open access journal, and it's in English. So I suggest to the neurosurgeons that perform this surgery, this surgical description. Grade. It's very simple. 0, no contact. Grade 1, simple contact. And grade 2, severe neurovascular contact, displacement, distortion, indentation, grooving. And location of the neurovascular compression. Divide anterior third, middle third, and posterior third. Posterior third is defined as the proximal third of the cisterna segment of the nerve closest to the root entry point. My casuistic between 2008 to 2024 is 69 cases, and I done 468 balloon, 23 cases of tumor. Most of them are epidermoid cysts, and posterior fossa separation 205. In my posterior fossa separation, severe vascular compression 139, arachnoiditis 14 cases, and no compression or very low-grade compression in 25%. Conclusion: neurovascular compression of the trigeminal nerve has been identified in most of the cases of TN. However, the absence of neurovascular compression in TN is also common. Interfascicular neurology provides good initial pain relief and long-term efficacy. Patients with IN may experience some degree of facial numbness, which was well tolerated by the patients, usually is transitory. This interfascicular neurolysis is the best procedure when vascular compression is not found in surgery, or when compression is low-grade, simple contact. May be considered a salvage procedure in patients with TN who do not respond to microvascular pressure or have recurrent symptoms. Thank you very much.